My name is Robin Hussa-Farrell, and I am the founder and CEO of Sharpen. Sharpen is a digital technology platform that brings together both thought leaders and evidence-based best practices into a digital framework. I launched the Fireside Chat series in order to really highlight the researchers and practitioners, clinicians we have the great fortune of being able to work with. In advance, I just wanted to sort of set the table with regard to best practices and safe messaging, given our topic today. We want to be sure to increase connections, connectedness, and start normalizing the conversation, given the fact that this is Suicide Prevention Awareness Month, and our topics today are focusing around best practices around screening and other postvention, intervention, and prevention. We're very excited to share those resources with you, but we also realize this is a challenging topic for many. I have pasted into the chat area a safe messaging guideline with other best practice, evidence-based programs that we may be referencing in today's program. I've mentioned you can say hello to us in the chat area. If you would like to stay connected, we will then have your contact information. We ask that you please mute your mic as we get started here. And when we're in the Q&A section of the program, feel free to unmute and speak to us there freely. In October, we have two fabulous fireside chats featuring Dr. Terry Pruitt, who is the Chief Academic Officer for Spartanburg School District 7, Ty Tyndall, Colin Bauer, and Ruth Schoonover, who is the president of the South Carolina School Social Worker Association. They're going to be joining us for a real practical tips and tricks from the trenches in terms of mental health and building resilience. We will also on October 20th talk about community-based mental health best practices with the co-founders of the Spartanburg County Behavioral Health Task Force and two other thought leaders within the region, Roger Williams, Carrie Rothschild, who will be sharing best practices as well. Those happen in October. We are so grateful to have you here today, Tom. Please feel free to just give us a little brief primer on who you are, what you've been up to the last 4 decades or so.
Thank you, Robin. I appreciate that very much. That was a wonderful introduction. Wish to say hello to everyone today. Thank you for attending. I've been a family practice doctor and teacher and professor since the very early 1970s. Had a lot of travels around the road. Over the last 20 years, I've been in the behavioral health space. I've worked in large behavioral health clinics as the medical director. I've also gotten into the entrepreneurial world of medicine. And recently, in the past 4 or 5 years, have begun working with an idea that I had that mental health issues are very difficult for primary care docs, particularly. Lack of time, lack of real emphasis. Began a company along with Dr. David Sheehan in 2016 called nView to mold the commercial world of the practice of medicine into what we had been doing for years in the world of research. So nView is a company that provides interesting assessments, scales, screeners, tracking tools in the behavioral health space. We provide psychiatric interview tools, screening tools, and really I think part of that is the fact that our thought about screening, for example, is the answer to that is everyone should have it. And so that's part of the message that we carry. What really sparked me into this was the topic of suicide, and an idea and a topic that's difficult for providers to talk about. I think a lot of providers are hesitant. And so part of bringing the right tools to bear was to make this a conversation with providers that could be a way to help their patients, and I think to some extent a way to help them, because medical providers, as we all know, have the same mental health issues as all the rest of the world. So we need to focus both on them as providers and on them as users of the tools. So that's what I've been doing for the past many years.
Wonderful. Well, it's really quite an honor to get to chat with you today, and we're so grateful that you could join us for this fireside chat. I do see that there's a couple other folks who just joined us today, so I'm just going to welcome you all, let you know you can say hi to us in the chat area, and we will be pasting certain resources and other information there throughout today's session. There will be an opportunity for us to take questions with Dr. Young at the end of our little chat. Maybe the last 10 or 15 minutes, we will open it up to you all. Dr. Young, I'm going to just have us get right started. You mentioned the Mini and the nView screener and sort of the work you and Dr. Sheehan have brought to the table. So why don't we just start right there? What is the nView, the Mini, the screening tools? Why are they, and why are they relevant, especially as it relates to mental health screening?
The Mini and the tool suite that goes with it are based upon years and years of research and validation around the world in multiple languages since the early 1990s. The screener is exactly what it says it is, but it's not like average screener. The Mini and all of its tools are focused toward correct diagnostic outcomes. In other words, providing a screening tool that screens not strictly for symptoms, but screens for the presence of potential behavioral health disorders, which is a little bit more specific than the other things that are currently out there and have become popular over the last several years. So the Mini screener leads to the ability of a provider to be able to do a good psychiatric interview, get to the heart of the problem quickly with an individual patient, and then with the information that the Mini provides them, allows the provider to make a more cogent and more accurate diagnosis of that patient's behavioral health disorders. And then we follow that along because we believe very strongly that you have to track the outcomes of the process of healing, if you will, whether that's by therapy, whether that's by medication, whether that's exercise as part of the program, whether that's yoga as part of the program. You really need to find out that the process that you're using produces the result that you're looking for. So the nView suite of tools takes the screener, the interview, and the tracking tools and brings them together on a platform so that providers can quickly and accurately get the process of behavioral health fully integrated into their practices. So that's kind of what they are. There's many of them.
Yes.
We have screeners. We do a lot of work in the suicide world and have a very validated and actively used tool for suicide tracking. And we could talk some more about that probably as we go through, but that's the basis of what we do.
That's fabulous. So let's talk a little bit. Anyone who knows me on this call or seen or collaborated with us over the years, I'm a real stickler for evidence-based sort of best practices and bringing those resources to the community. I certainly know I've had the privilege of getting to work with you almost a year now. We've integrated and tried to partner on a couple of different efforts. What is the research, even just broad brushstroke? Because I think it's fairly, I find it really awesome. In fact, the level of research behind the nView, the Mini screening tool. Can you just give us a picture of what the validity is?
Sure. The original design of the Mini and then from that came the screener and the trackers was developed by Dr. David Sheehan in the very early 90s, mostly as a response to a request from a pharmaceutical company whose product had failed their phase 3 trial. in which, as most of you know, a phase 3 trial for a pharmaceutical company is an enormously expensive process. And in failure, it's a big loss. So when they brought the data to Dr. Sheehan, one of the things that first became clear was the fact that they were doing a lot of having patients interviewed by multiple psychiatrists, which immediately introduced a great deal of bias. And so one psychiatrist might say the patient was depressed, another might say it's anxiety, a third might say, well, it's all related to PTSD. And so the failure of good diagnostics at the front end resulted in the failure of their trial. So they asked Dr. Sheehan to look at that. He was then at Harvard, and he and several psychiatrists around the world developed this tool that allowed people to ask the right questions in the right order and get the right diagnostic criteria. And so that was the early beginnings of the Mini. Portions of it were given to the U.S. military back in the early 90s, and the U.S. military has used it for many things in war fighters over the last 20 plus years. So as the tool began to grow and get validated, there was a formal validation done in the early 90s for accuracy and for repeatability, if you will, or reliability. All of those were in the area of 90% accuracy. Reliability was high. Reproducibility. Are you hearing me?
Yeah.
Okay. Reproducibility was a key element. So could one provider use the tool, another provider use the tool, and could they come up with essentially the same data? And that was well proven. To date, the Mini has been placed in about 160 languages over time. There are about 17,000 sites in academic journals around the world for the Mini. If you Google on Google Scholars, for example, if you Google the Mini, you'll get tired of looking through the pages. At any given time, the Mini or one of its associated tools is used in approximately 50% of all the clinical trials that you see listed on clinicaltrials.gov. So it's been around, it's been available for multiple languages, and so its validation has grown over the years. And in the late 1990s, early 2000s, the Mini Kid was developed, which is the same type of tool, but for children between the ages of 6 and 17. And it has quickly become the tool of choice for psychiatric interviews for children. And it's been validated by age group.
Sure.
It's been validated linguistically. In other words, can children understand these words? Yeah. And so it too is in play around the world today, and we have it in multiple countries around the world today actively being used. So its validation is high, its acceptability is good. All the organizations in the world that assess the reliability of trials, FDA, European Scientific Union, Asia Scientific Groups, all have validated this as an acceptable tool in the research world. So what nView has done, and this was kind of my passion about it, was how can I take these and put them in the hands of people every day who practice medicine, particularly in the US, so that our patients have quick and accurate diagnostic opportunities, and it allows the provider then to feel more comfortable in working in that behavioral health space.
That's fabulous. So, Dr. Young, let's talk a little bit more pedestrian, I guess I will say, and more lay person. Who should be using the Mini, where it is today? What is your guidance for, I realize that with over 17,000 research publications and so forth in the history of the Mini, where are you guys today? Who should use it today? And what are sort of the best practices around that?
Well, I think in the space of sort of the practice of medicine at a clinical level, The role of screening cannot be underestimated. All the groups, the U.S. Public Health Service Task Force and others, recommend screening for behavioral health disorders.
Yeah.
American Academy of Pediatrics is the same. So it begins there, I think. The many tools begin at the front with a screening that allows either children or children and their parents, adolescents and adults, to get the initial look at, along with their provider, what may be going on. From that, then, the interview provides the real meat of the matter in terms of getting the right answers to the physician or the nurse practitioner, whoever the primary care provider. Maybe a therapist, it could be a PA, it could be an NP, it could be doctors, internists, pediatricians, any number of people. It has a role, for example, in the emergency room for emergency room doctors to get accurate diagnostic information quickly on patients in the ER. So it's that combination of screening followed by the interview. And then once that's been determined and the provider has made some decision about what the treatment program is going to be, then that's the role for following and tracking, making sure that what we're doing is going in the right direction, letting us see on a daily or weekly or monthly basis that our patient is making progress. And I've found in my own practice that when patients can see that they're making progress, that's an important part of the therapeutic interaction. So these trackers have more than just the physician or the clinical user, but also for the patient. So that's kind of where it fits. It fits at the pediatric level, it fits at the adolescent level, fits at the adult level, and adults of all ages, because as we think about suicide particularly, it is not a generationally unique problem. So the ability to get to these answers accurately and quickly is important, because one of the things we know, for example, about getting to the information quickly in this country, the average time from the onset of a psychotic symptom, such as symptoms of schizophrenia, to the actual diagnosis of that, the average time length is 10 years. And that's just not quick enough. And we're now learning that we need to observe those signs early, in early adolescence, for example, because there is good information and good studies now coming out that if we can impact that group of people at a much earlier age, we may in fact be able to push down the morbidity of schizophrenia and some of the schizophrenic disorders, schizoaffective and some of the others. And we also know that, for example, of the top 38 psychiatric diagnoses right now in this country, 34 of them have increased suicidality ratios over normal folks. So all of these disorders, all 34 of the top 38 have the ability to drive suicidality, for example. And so the ability to find that and track that and identify it with the patient are critical.
Yeah. Can you address, just in terms of the use case of the mini and or the screener within a school district? I do have a lot of school-based professionals that are on this call today. And by that, I mean, can it be delivered in a school setting? And walk us through the appropriateness of with or without parents.
Okay. Yeah, I think those are great questions, and we get those a lot of time. The mini, because it goes down to age 6, sort of fits the entire school setting, with the exception of pre-K. But when you talk about particularly first grade on, the problem obviously is that interview with a child with a screener should be done early on with the parents, probably up into the ages of 10 or 11 or so. And there's no hard and fast detail on that. But the reality is smaller, younger children, particularly 6 to 8, probably need the parent present, and they need to work through it together with them. Although linguistically these have been validated for children, the reality is it's probably best with a parent. As you get into the preteens, particularly the 10s, 11s, 12s, and on up, these screeners are perfectly appropriate for asking them or handing them to the adolescent or pre-adolescent to be able to answer them on their own, on a tablet, for example, on a phone, which everyone has these days, but the tablets are particularly good for that. And then it provides you at least a rapid overview of what's going on in the mind of that child in terms of how they respond to the questions. It gives you some intrinsic data. In most states, behavioral health data is considered private at age 14. So certainly with 14 and up, these are things that you can either hand to them or you can email to their personal email box. If you're going to email these out early, you probably need to have parental permission for anybody under 14 to say, I'm going to send your child this tool, and maybe you need to work through it with them. But we find that it's across that broad sweep of the K through 12 age bracket, that it is partially dependent upon the person that's using it and their understanding of that individual child. But certainly 12 and up, these can be administered directly to children.
I want to talk, because we're here talking today specifically about suicide prevention, given the fact that this is Suicide Awareness Month. And according to the American Foundation for Suicide Prevention, we know that there are one or more things going on often with comorbid conditions. These could be things like anxiety and or depression, but it could be isolation or loneliness. It could even be a little bit of mania and feeling euphoric. So I was curious, with your expertise and what you've seen through data with the mini, with your work, can you talk about some of these warning signs and the others that you've been seeing?
Well, yeah, I think you can talk about warning signs. I think the first thing that I would highlight is that the vast majority of people who attempt suicide and are successful don't really have depression. So when people talk about, well, if you have depression, that's really the major risk factor, it's clearly not the major risk factor. All of the things that you listed are potentials for noticing that person, if you will. I often tell people that what you, as the observer, feel or think or have in your gut about that person, that's probably good information. You probably need to listen to that, whether that's their a little bit hypomania, whether they're drinking more, whether they're staying out later, whether they, got rid of their friends, whether they changed from a nice, warm, lovely adolescent into a gothic, strange person that you didn't know. All of those things could be prodromes. So really saying that there are, like 5 or 6 or 7 and those are it, that's not true. I think often you have to use your own personal intuition, whether it's your child, whether it's a friend, whomever it might be. And I think the key then there is you have to talk about it. And I think certainly one of the things that we hear from professionals, a lot of health professionals have difficulty talking about suicide. Physicians, it's difficult because to a physician, a suicide is essentially a bad outcome, because we're taught, that death is the enemy, and that's who we as physicians fight on some regular daily basis. And so somebody who doesn't want to engage with that fight is suicidal. That's problematic. And so for a lot of professionals, there's a hesitancy to discuss that. And I think years ago, and a lot of us probably understood that from training, people said, well, if you talk about it, if you see these kinds of symptoms or you have this gut feeling, you ask people about it, that's going to make them do it. Well, that's clearly mythical thinking. And we need to get people away from that and say, look, it's not about it's not about a set of symptoms that everyone has. The other piece of that, Robin, I think, and when we talk about the symptoms, is people sort of have this conceptual framework of suicide, and that is somebody has the idea, okay, and then somebody says, well, how would I do that? And then somebody says, when would I do that? And then they start planning for that, and then they get there, and then so it's this linear kind of progression. Clearly not the truth. Suicide is a non-linear disorder. There are people who will commit, there's some groups, subsets of suicide, what's called suicide impulse disorder. They have thoughts of suicide every single day, every day, all the time. And so they fight against that impulse. That's a totally different picture, if you will, than the rapid deceleration into suicide of somebody with an event. It may be very long term. I know one of my patients that I knew well, had delivered, who was an Olympic skier, won a silver medal, and the next year drove up into the mountains in Salt Lake City and shot himself. But when you looked back at Speedy's life, you understood that there had been a lot of pain and anguish in years past that were part of what he grappled with on a regular basis. Even though he became successful, wildly successful as a skier. And the same thing's true of a lot of athletes that we see, that you think, wow, they're great. They've got money. They've got, the best there is. And you just have to look at some of the other award-winning Olympians, for example. Not too long ago, we lost a bobsledder in the Olympics. We had a summer Olympian, Michael Phelps, who has now become sort of the voice of how depressed and angry and suicidal he had become, even as the most successful Olympian in history. So I think you can't bank on the symptoms. You have to bank on, if you feel it, and that's there with that person, then you have to talk about it.
Yes.
And I think that's clearly sort of what we need to dispel, is that every person is going to have some obvious symptom.
Yes.
And they don't. And that's sometimes the hardest thing for families who say, well, why didn't I see it?
Yep.
Well, you don't always see it. It's not always right in front of you. Yes. And so if you're not having that conversation, even with younger kids, I know in my all my kids that I see now are college students. And, anytime one of them comes in, because I don't know them all each individually that well, but I always ask, are you thinking about that? Are you lonely enough to be scared? So I think all of that bespeaks whatever that individual presents to you. And if you feel it or think it, you need to ask it.
Very good. One of the resources that I did paste into the chat area is a suicide prevention document that contains all kinds of evidence-based strategies for getting that conversation started. There's a lot of programs out there. We might talk about a couple of those today. Those are kind of after the screening, and you need to actually do something about it, maybe provide some training. There's a couple of those resources listed. So for anyone on this call and or watching this, there are ways to engage in that dialogue safely and appropriately that really do have shown to move the needle in an amazing way. One of the things you and I have talked about over the last year almost that we've gotten to work together, it has been within your screening tool. You have shared with me a couple of interesting ways you have modified your screener or added questions to the screener to make sure we are absolutely catching anyone who might be contemplating suicide. Without putting you totally on the spot, which I am doing, I think you know what I'm talking about. You've mentioned to me in the past that there's a couple different questions you all have architected. I would love to pick your brain on those a little bit here.
Okay, yeah, there are, I think, when people think I'm going to screen for suicide, most of the screening tools out there now come from the position that everybody who commits suicide is at first depressed. And so if you start with that mindset, obviously, if they don't fall into the depression, then you're going to think things are okay. Or, for example, if you say in the past 6 months, well, one of the things, and Dr. Sheehan has worked in the suicide world for many, many years as one of the world's leading authorities. So one of the things that he has learned, which we build in, is that you have to ask the right questions, because people who are suicidal often want to keep that to themselves. Yeah. So unless you march through the correct question, for example, if you say to somebody, have you had suicidal thoughts in the last 6 months? Now here's the scenario for that. This patient decided 9 months ago that on their next birthday, 10 months from now, they're going to commit suicide. And they really don't think about it much. They don't think about it every day. So when somebody asks the question, you say, and you're now 7 or 8 months away from that original thought process, and you ask them that 6-month question, the answer is no. Okay? So unless you begin to think that, okay, so that could truly be a no, or possibly that could mean you've thought about it, you've already made a decision, so you're not thinking about it. Your decision is that you're going to commit suicide here. So you have to ask a bit more specific question, so that when we get a trigger in our screener, the next thing we resort to is a set of suicidality, what we call suicidality tracking questions that let us quickly go through and exclude those exceptions that people have made, and you find out, well, yeah, I decided last year at my birthday that I was not going to live another year past that. On my next birthday, I was going to take my life. And you say, I would have missed that. So I think there are specific questions, and I think there's a specific sequence in asking those questions to really get the full scope. And again, you may have people with bipolar disease, for example, that if you say, and they've been well, or maybe they're on a drug that's doing well, and so they haven't had a manic episode in a long time. So the question needs to be, have you ever, during one of your manic episodes, had suicidal thoughts or ideations? Because if you say in the past 6 months, they may not have had a manic episode.
That's right.
And when you realize that a lot of people with other underlying behavioral health disorders commit suicide for all kinds of other reasons. Yeah. And so I think you have to look at each of those practicalities, or each of those what we call phenotypes, and make sure that you've asked a question about that. Because if you haven't, I can guarantee you over time, you will miss one. Yeah. And there's nothing more discouraging than missing one. Yeah. For everyone involved. Because anytime you have somebody successfully commit suicide, the one thing that you have to think about as a provider or as somebody who's working with that family, you have to understand that when somebody successfully commits suicide, it affects about 125 people. Okay, so I liken it to throwing a pebble in the pond. And the worst part is that 33% of those 125 will be deeply affected for years.
Yes.
Okay, So this is not a disease or a process that is singular, if you will. So again, you've got to be asking the right questions to
That's
get
right.
the right data, or the outcome is not just the one person. It's this vast ripple in time. It's the effect on other people in their environment,
Yes.
that 130, that 125, or that 133 or 150 or 160 people that they touch over time. So when you think about that, and you think about on national statistics, what's 50,000 times 125? Well, that's a big number.
Yeah.
That's a big number of people. And so it's important to ask the right questions so that you get the right answer, so that you prevent the bad outcome.
You and I have talked about this as well over the year, and I was certified in a program that is called the Postvention, which is an evidence-based model out of NAMI, New Hampshire. And we talk about postvention being prevention, so that we are talking about that ripple effect. We are talking thoughtfully and intentionally about sharing stories of lived experience. And we know that the more we learn, the more we can do a better job as a community of kind of building those protective factors. So it's in that spirit that I would invite you to share your personal family story with us, if you would be so kind.
Sure. I think my story of suicide goes back to the early 70s. And I had come from an experimental program with the federal government and the National Health Service Corps, had helped get that going, and decided to move home to Dallas to work at the federal offices in Dallas to take care of my grandfather, who was getting older and lived on the ranch, a place that I had spent half of my life. The other half was in a metropolitan city with a motion picture producer for a father. And so I was there taking care of him. I'd go out to the ranch in the evenings and do whatever needed to be done, and didn't notice kind of what was going on because I wasn't there all day every day. And my grandmother had died several years earlier in a tragic criminal act, and he had really talked about it. We really talked about it a lot, and he seemed to be doing really well. And then one day he wasn't. And I got the call from the sheriff. So that was my first experience. And I looked at myself and I said, how did I miss that? And I kept saying, I'm a doctor. I'm supposed to, I do this for a living. But I didn't see it, much like everybody else I've talked to over the years. Much like a lot of the people that I've worked with in other families when that happened. So it was enough to make me sort of more aware of it through the rest of my practice years, but it wasn't enough for me to miss noticing it the second time. And that second time was when I got the call from one of my sons. All three of my sons were living in Missoula, Montana. And I tried, in the story, I tried to get a hold of my oldest son, who didn't live with his two brothers, for several hours on a Sunday, on a Saturday night, which I usually call them pretty much every Saturday night. And he didn't answer, and he didn't answer. He had recently, he and his wife had separated and were in the process of a divorce, so I called her. She couldn't get a hold of him, so I sent his brothers over to his apartment to get the call from one of the twin sons to tell me that Thomas was dead. What happened? Well, we got the story. He had been into some drugs. He intentionally overdosed and left a very poignant comment on a small piece of paper. And I got that call. I will never forget. I was on call for the hospital. I had just gotten a call. I was just getting my clothes on to go take care, admit a patient for congestive heart failure. Got that call and literally could not function. Had to pick up the phone and call one of my friends who was a physician in my group and say, you got to go take care of this lady. I can't do this. I told him why. I was at the time engaged and called that person. She came over and we figured out how to get to Missoula. But all the time thinking, why didn't I see this? But again, often it's like anything else. You're not really being a provider when you're talking to your kids often. So you sort of get this dichotomous process. But it was then that with that event, that suddenly tripped me over into a full-time behavioral health world to understand that we just weren't doing enough. We weren't doing enough at my level as a provider. We weren't doing enough at the level of people to take care of people. And I look back, that was in 1999, it was 21 years ago. And unfortunately, we're almost in the same boat still today with behavioral health. We're in the same boat with substance use disorders. People have thrown money at it, I think sometimes in the wrong ways. But for me personally and for our family, it created a real dramatic focus on understanding how each of us was truly feeling. And even though his brothers had some troubles over the next 20 years, each one of them has at least been able to talk about what they're doing, what they're feeling, how that affected them. So now, 21 years later, I have one son who's a substance abuse counselor because he got the message, and another one who's working towards his master's in counseling right now. So there's always maybe good that comes out, but I think from a personal level for me, suicide has become kind of the passion of the day for me. Yeah. And that is, I think the place that we have to focus is on making the conversation about suicide as common as the conversation about coronavirus or meningitis in adolescents or any of the other things that we see. Because when you understand that it's not always, 17-year-old kids who jump off buildings. The other experience, I think I shared this with you, when I was teaching trauma surgery for Baylor and in Waco, and I was head of the trauma group and teaching residents. One afternoon, we had a 6-year-old kid come in who'd been struck multiple times on the interstate. You don't think about that when they say that. You just, you go to work. And so we miraculously got this kid into the operating room and when I say multiple fractures, I've never seen that many broken bones in a living human being. And the spleen had to come out, all that stuff. So several days later, because he wasn't my patient any longer when he got out of the ER, I just went up to see how he was doing, up into the pediatric ICU. And so I was sitting there and he was awake and talking, which was, again, a bit of a miracle. And so I just asked him, because I suddenly realized he got hit on the freeway and wasn't in a car wreck. And I said, so what were you doing on the freeway? And he looked at me with little 6-year-old eyes and said, well, I just didn't want to be here anymore. And that was my first experience with thinking, yes, children think like that. Yes. They don't get the enormity of it. They don't get the longevity of what happens, but they do have the feelings. And so that was when I, really along the way started learning a little bit more about this and now understand that really this is about everybody.
Yeah.
Okay. It's not just adolescents. It's just not the most common group. One of the most common groups is the pre-adults, that group between 24 and 30. Somewhere in that, around that 27 age range in the middle, a lot of people commit suicide then. A lot of people committed in mid-adult life, in other words, between the 40s and 50s, and certainly a lot of seniors, but often we don't get that as the outcome. So I think you have to, in the sense of understanding it personally, you have to be able to talk about it. You have to be able to engender that conversation in your homes, with your children, that people get sad enough. If you get that sad, however that conversation plays out, that's a critical, important factor.
Yeah. Absolutely. Well, thank you so much for sharing your story. I think every time communities can learn from lived experience and from family members, and especially physicians who have been there, done that on multiple occasions, we get a little closer to normalizing these conversations around mental health and the whole point of today, which is the earlier we can screen, the earlier we can maybe identify all these things that may not be pointing directly to suicide. We can identify them earlier on.
Right.
You touched on the one population that we're often missing. I just wanted to make sure that you've said everything you want to say about our aging populations. Is there anything from your perspective we need to be doing to paying attention to that age group? Because we are often focused on the young, but what about our aging population?
Well, I think elderly have problems and certainly commit suicide not infrequently. It's often double. It's often a homicide suicide. In older couples, one is failing, one doesn't want to be without them. I think one of the key elements to keep track of in older patients and elderly patients is really this: what's your level of loneliness? Because that is one underlying sensation common to the human animal. That as I age, particularly, that I understand that being alone is a dangerous position. People don't do well alone, particularly people who have been in a dyadic relationship for many, many years. Elderly people make decisions often based upon reasonable reasons, if you will. I'm dying. I don't want to be a burden. We hear those kinds of comments all the time from people often in hospice. But the elderly need your attention. That needs to be a question that we ask. How are you doing? How are you doing with? Are you lonely? Because often if you ask them, they'll tell you. But if you don't ask, they won't. They don't bring it up. So it is important, and they are a significantly growing population of people. And I think the last thing, clearly in the COVID era, we have to understand that we are going to see more suicides in this country. The number, rocking around 45 or 50,000, that number is going to be 70,000. And it's going to be more veterans. It's going to be more older people. It's going to be more pre-adolescent or pre-adults. It's going to be more adolescents. Because because right now, everybody's stressed. A recent study that was done, was published fairly widely. Some people just asked, have you had any thoughts of suicide in the last week? 25% of all the people who answered said yes. Well, that's a staggering number. And without attention to it, without internalizing how hard it is for you to talk about it, it's just as hard for that other person, but you've got to be the one doing it. That's, I think, key element is this whole conversation of normalizing, at least not normalizing completing suicide, but normalizing thinking and having the thoughts and saying, yes, because I think I heard Dr. Sheehan talk once, and he said, if there's a human being on the planet that has never thought about taking their own life, they're probably already dead.
Right.
And so I think that's important for us to live our own experience and use it. So.
Absolutely. Absolutely. I'm going to pause here. We are with Dr. Thomas Young of nView, who is sharing expertise, guidance, and best practices around suicide screening, along with some lived experience wisdom. I'm going to pause here for any questions. If you have a question, feel free to put it into the chat area or unmute your mic, and you may openly ask Dr. Young now. So I have two more questions for you, Tom, and then I will flip it around on you, see if you have any things you want to add, given COVID, given all the conversation already we've had today. We talk a little, we do talk about getting the conversation started sort of appropriately. I'm just curious from your perspective, what your advice would be in that regard. Like, you've already given us some ideas, especially as we're looking at COVID here. We're looking at sort of increased risk all the way around. What might be some great strategies for getting the conversation started earlier on?
I think for me, I'll just talk about what I've been doing. I often start the conversation with my patient population by saying, I've been feeling pretty stressed out. I've been feeling pretty bad. Had some really dark thoughts at times. So, I think that's common. And I think, it's something we just need to know. How are you doing with that? So I think sometimes we have to, as providers, we have to put ourselves out there a little bit for somebody to trust us enough to talk about that. Okay. That's a difficult topic for people to say when they're feeling suicidal. They don't readily open up. If they did, we probably wouldn't be having these conversations. So I think the ability to sort of put yourself out there for somebody, it is a strategy. It's one that I use, saying, thinking about suicide is not a bad thought. Okay. It's not the best thing we could do. So let's see if you're having those thoughts, can we talk about it? And the other one that I've used over the years is to sort of, as I talk to people, to say, look, if I'm going to take care of you, I'm just going to ask you for one thing. And I bet you a ton of my patients would say they've heard this. I'm going to ask you for one thing, and that is, if you decide you want to take your own life, I'd like for you to call me first and let me know, because I've had bad experiences and I don't want to read about yours in the paper. And I think that has for many people opened them up to be able to say, oh, really? And to say, how it made me as a parent feel, how it made me feel as a grandchild. For them to understand and get a look at the other side of what their action may be, which is, how's it going to affect the people I live with? How are they really going to feel? And I have this thing that I talk about all the time. I'll pull it out of here if I can find it in the right spot here. It's well, I don't have it. It's a little poem, and I'll send it over to you, that talks about, it's not really a poem, it's just a set of thoughts about when you lose someone, how you feel. And I've handed that over the years to a lot of people so that they understand, because sometimes people are feeling alone, lonely, unloved, uncared about. And I think often just that is enough to help move them to a different position.
Yeah, right. Just a nudge, even in the right direction. There's a question in the chat area. How large an impact has the pandemic had in your practice? It's
been enormous in my practice. just from, I'm the doc of all ilks, of everything at the college. And the college has about 1,000 students, 200 of them, 128 of them were on campus all summer because they're from out of the country. And I saw a tremendous increase in them calling me up and saying, can we talk? Or calling the counselor up, and the counselor's calling me and saying, you need to talk to such and we've seen an enormous spike at the substance abuse clinic that I'm the medical director for. I mean, enormous spike, all COVID driven in people. You know, they overdose and they end up in the hospital, and then they end up with us. And that's just, I mean, around here, there aren't enough beds right now. I mean, it's gotten that problematic. The practice at the clinic for adults and non-college people is standing room only right now, to the extent that we've even started some online group conversations because there's just not enough time in a week for a therapist to talk to everybody. So it's been an enormous uplift, and that's true across the country. And people that I talk to, we're all seeing enormous spikes in this post-COVID, everybody keeps saying post-COVID, in this current COVID world. And I think the scariest part, at least for me, and I think a lot of the folks I talk with and work with, is that this isn't going to be over soon. Okay, this is not going to be magically, this is not going to be like Christmas. And this is not going to be the same next year. It's probably not going to be the same the year after that. And so I think there has been an uptick, and we do need to pay attention to it. And there is a prediction that we'll see 50 to 60% more suicides over the next 2-year period. And that becomes a really big number. Unfortunately. So yes, it's a dramatic impact.
And all the more important to be screening and trying to identify and getting earlier identification as soon as possible.
Right. Kind of our mantra at nView is screen everyone. That's what you do. You screen everybody. You ask the question to everyone. You put mental health disorders in the forefront and make them part of your regular conversation. Okay. And I mean, that's really the first thing you have to do. You've got to find people and help them find themselves. That's the other part.
That's really awesome. Any last 2 or 3 suggestions that you might give to anyone participating today? 2 or 3 easy or quick things that they could do tomorrow, this week, to try to get ahead of both mental health and suicide challenges that they're faced with?
I think the first thing I would tell people in the helping professions is deal with your own issues that you might have around behavioral health or suicidality. Figure that out. Understand that. Because if you don't, then from the very get-go, you're not really doing the best you can. So I think help yourself. Figure yourself out first. Secondly, again, we go back to each person in a provider role, whether it's an educator, whether it's a therapist, whether it's a physician, nurse practitioner, whomever. Think about asking everyone. You got to screen everybody. Okay, we know that, and we know that works. And then I think we, as a profession, in the helping profession, have to make suicidality a part of our jargon. It's got to become as easy for us to talk about as telling people that they're going to die of hypertension. We readily say, if you keep eating like that, you're going to get heart disease. We go through all that. But if we don't look at them saying, if you get really lonely, you might kill yourself. That's not what we do. And we need to. We need to get it into our jargon.
Absolutely. Well, Dr. Young, thank you so much for joining us today on this fireside chat. I am going to just see if there's any questions I haven't asked you or that we haven't asked you that you want to make sure you address.
No, thank you, Robin. It's been a real pleasure to chat with you as always, and to have some other people to chat with. And if there's ever anything I can do to help any of these folks, or feel free to give me a call, and or if it's an nView, give one of us a call.
Will do. Absolutely. Thank you, and be well, everyone. Great to see you.